Well, the ATAC trial has been going for a long time, and we've published 10-year follow-up some years ago. One of the important aspects of that trial is that we've set up a thing called TransATAC, in which we were able to get the blocks from almost all the patients in the United Kingdom and a few from other countries. And as a consequence, it's produced an incredible resource for looking at biomarker studies. And we have most of the major genetic scores that we've actually evaluated on this. So it's the only database in which we actually have direct comparisons of most of the major studies in terms of predicting prognosis based on tumor markers and genetic factors. So it's been an incredible resource, and we've continued to mine that, focusing now more on what predicts late recurrence. The panels that we've looked at they give about the same predictive value for looking at who's going to get a recurrence in the first 5 years. Our own simple one, which we started with, we called I8C4. It was a simple immunohistochemical marker just looking at estrogen receptor, progesterone receptor, HER2 positivity, and Ki67. And it's essentially a measure of cell proliferation. And it works as well as almost all of the other ones. Nothing works better than that in the first 5 years. And they virtually all work the same, because essentially it's proliferation that's the key driver in terms of the recurrences in the first 5 years. But what's been interesting is in more recent work, we've actually found that there are substantial differences across these different panels in terms of predicting recurrences in the second 5 years. So because breast cancer is a very long-term disease, it's really important to be able to predict what the recurrence rate is going to be over the first 10 years, not over the first 5 years. It's one of the few solid cancers in which non-recurrence in the first 5 years is not an indicator of disease eradication. The recurrence rates in the second 5 years are almost as high as in the first 5 years. So knowing what's going to happen in the second 5 years is very important, not only for deciding whether you need chemotherapy up front or whether you should consider extended endocrine therapy into the second 5 years. So many of these things have been looking at that. In fact, we're trying to set up a pilot study, which we're struggling to make work, to actually look more specifically at late recurrence treatments. And many of the studies have said after 5 years of endocrine treatment, should we add 2 years or 5 years? In fact, if it's tamoxifen, there's pretty clear evidence that extending treatment beyond 5 years is a good idea, and it's just a question of selecting which patients will benefit most. But for aromatase inhibitors, because they're more effective in the first 5 years, it may be that 5 years is enough. So we've had studies of 2 years additional treatment versus 5 years additional treatment, which are the same, but they don't address the fundamental question is, do you need any additional endocrine therapy after 5 years? And our study was aimed at looking at, if you've had just an AI and not tamoxifen, should you stop at 5 years or continue for another 3 years? That study is struggling to recruit, so we may not be able to give you the answer to that. But I think it's one of the fundamental questions now is, with AIs, what is the appropriate duration? And there's even some evidence, mostly based on the big 198 data, which switched from an aromatase inhibitor to tamoxifen, or vice versa, at 2 years, that the patients that had 2 years of an AI followed by 3 years of tamoxifen did just as well as the patients that had had 5 years of an AI. And it raises the question for low-risk patients, can we actually just treat them for a couple of years? Do we really need even 5 years of an AI? So those, I think, are important open questions. Of the tests that we've looked at in ATAC, there are two that have stood out as being particularly useful for predicting long-term recurrence. And the one is the nanostring test, which is called Prosigna. And the other one is the EpiClin test, which is essentially now Myriad's test. And both of those do seem to provide additional predictive value in the second 5 years, whereas many of the other ones show very little effect in terms of predicting late recurrence.
So we were speaking with Jonathan Lancaster yesterday from Myriad, and he was very enthusiastic about the MyRisk.
Now that's a different thing. That's looking at risk of developing breast cancer. Yeah. So basically that's an attempt to pull together genetic factors. And we've been doing some work on that too. We have a thing that's either called the IBIS model, or it's become more commonly known as the Cuzick model, for predicting who's at increased risk of breast cancer. And recently we've added a SNP, or single nucleotide polymorphism score, to that, which is based on 88 genes, which are much more prevalent than these ones in my risk. But the risk individually are very small, like in the order of 5 to 10% higher or lower risk. So individually they're not important, but when you have a panel of 88 of them, it adds really very useful information for who's at risk of breast cancer. And we think this is going to be important not only for identifying who's at high enough risk to consider preventive therapy with an aromatase inhibitor or tamoxifen, but also beginning to think about risk-adapted screening, that it's not a one-size-fits-all for breast cancer screening. Some women need more screening, like every year, or even MRI screening if they're high risk. Some need a lot less screening, and possibly even none. So if we could begin to identify who really is going to benefit from screening, give them more, and then also identify those for which breast cancer is not really a problem for them, they're very low risk, then we might be able to avoid screening. So there's a lot of interest in using these risk models for who's at risk of developing breast cancer to guide screening and preventive strategies.
And I suppose following that thread of a risk for cancer development and then cancer recurrence, and then just moving cancer into kind of the lifetime, you get your annual checkup to see if there's any change, I guess.
Well, you may not need it every year. That's the whole issue, is that you certainly need a good check at baseline. In the UK, annual checkups are not so often done, but every 2 to 3 years, a mammogram would be if it's 3 years in the UK, it probably should be every 2 years for the average woman. But some, you're going to be able to say, look, your risk is very low. You don't need to, you've got other things to worry about in terms of your health than breast cancer, which is a nice statement to be able to give if we can give that reliably. So that's a very important and challenging area. You clearly don't want to get it wrong. And we will get it wrong sometimes, as all these models are only models. But we feel that the idea of equity is not that everyone should be screened the same, but everyone should get the same benefits. And that means women at higher risk should get screened more often, and possibly with more aggressive methodologies like MRI. And some at lower risk probably don't need as much screening. And the hope is we would be able to find a group that don't need any screening. I think we're not there yet, but I think we could be beginning to find of the order of 10 to 20% of the population where the risk is low enough that 5-yearly screening might be enough. Breast cancer is kind of leading the way, but that's going to be important for all the screening programs. Colorectal cancer screening, if we can begin to say who's at high enough risk they need endoscopic screening maybe more regularly, who is not going to get colorectal cancer at very low risk and maybe doesn't need much screening at all. It's really an important area, I think. We're just beginning to delve into better risk assessment programs. And the reason that there's interest is we can do something about it. If you start doing risk-adapted screening, you need to be able to predict risk. So having a use of this information drives the desire to get better information.
And then hopefully taps into cancer prevention strategies, looking at the social causes.
Yes, absolutely. And well, my vision is that we should think about renaming breast cancer screening as a breast cancer prevention program. So you go along, you get a risk assessment, you have a trained nurse who can talk to you about what your risks are, what you can do to lower your risk. Even think dietary issues, exercise is important. And we'll be able to begin to tailor that more and more as we learn more about who's at risk of which particular kinds of cancers. So I think it is clearly the way forward, that this idea that screening is the same for everybody and it's a mass production thing has got to change. We've got to begin to personalize that.